Today and the next day, we will discuss about the cancer chemotherapy, principles of the cancer chemotherapy and some drugs, different names of the drugs as well as the classification of the drugs, those are used in cancer chemotherapy. Now, you have read about the cancer in pathology, so that is cancer may be, that is malignant growth. When the growth of the cells is unchecked, when the growth of the cells there is no apoptosis, so ultimately that leads to different types of the tumors, that may be a solid cancer, or there may be different other types of the cancer like hematological cancers. Now, the principle of the management of the cancer, there are mainly three. One is the surgery, one is the radiotherapy, and the third one is the chemotherapy by means of the chemotherapeutic drugs. Now, why these are also known as the chemotherapy like that of the antibiotics? Antimicrobial agent or antibiotics also acts against the foreign pathogen like the bacteria, virus, fungus, etc., and ultimately kills them. And by means of this killing, these drugs also have some adverse effect on normal host cells also. In case of the cancer, our host cells proliferate uninhibited, and these host cells also behaves like that of the foreign cells. So that's why when we are using some drugs as chemotherapy against those cells which are malignant, which goes unchecked, which ultimately not inhibited by means of different types of the inhibiting factor normally present in our body, these drugs act against them. Apart from these drugs also act on the normal host cells also. That's why these are also toxic. So this is the cancer or neoplasia characterized by unregulated cell division, avoidance of the cell death, tissue invasion and ability to metastasize. Invasion of the tissue. So when their invasion of the tissue happens, that becomes malignant and ultimately there will be metastasis. Metastasize to different types of the cells all over the body. So a neoplasm is benign when it grows in an unregulated fashion but without tissue invasion. So the proliferation or multiplication of the cells is unregulated, uninhibited, but tissue invasion does not take place. So this is a benign tumor. But when the tissue invasion happens, it becomes malignant. So malignant neoplasm, tissue invasion happens. So cancers are named based on their origin. That may be carcinoma, sarcoma. Carcinoma means that is mainly derived from the epithelial tissues. Sarcoma means that is mainly derived from the mesenchymal tissues. And there may be different types of the hematological cancers like leukemias, lymphomas, plasma cell dyscrasias, etc. So cancer chemotherapy is treatment that involves the use of the drugs to destroy cancer cells. So mainly we are using like that of the antimicrobial chemotherapy. So if you are asked that what are the different types of the chemotherapy? Chemotherapy may be antimicrobial chemotherapy, that is different types of the antibiotics, antiviral drugs, antihelminthic drugs, antifungal drugs, as well as cancer chemotherapy, those are active against the oncogenic cells or cancer cells. So before 1940 there was no treatment for the cancers. Then when there is large tumor, mainly the surgery was done, that is debulking of the tumor. And then the radiotherapy came in the 1955 and 1965. Only after the 1965s, chemotherapeutic drugs came. Newer and newer drugs are continuously coming, and now there are different target therapies are continuously coming that can target exactly where the proliferation, uninhibited proliferation is going on. More and more target therapy, different types of the monoclonal antibodies, different types of the checkpoint inhibitors. These are the newer drugs. So rapid growth in the drug, newer drugs mainly now happening in case of the cancers, different types of the cancers. And now we have immunotherapy and gene therapy also. So now the goals of the therapy. When a cancer happens, there are different types of the cancers. Some cancers are properly curable, that is the cancers can be cured. Some cancers can be palliated, that is maximum it can be done so that the quality of life of those patients can be improved, but the cancer cannot be do away with completely. Insensitive or less sensitive, but life may be prolonged, this may happen. That is, there is no direct action on the cancer cells, but we are giving some drugs so that the life of those persons who have cancer can be prolonged. Now there is concept of the adjuvant therapy. Adjuvant therapy means, so we are giving some surgery or we are giving some radiotherapy on the cancers. But even after doing some surgery, even after doing some radiotherapy, there may be some micrometastasis, and there are minute number of the metastatic or cancer cells will still remaining. This is in contrast to the antimicrobial chemotherapy. What happens in normal antimicrobial chemotherapy? We kills or we stop their multiplication in maximum amount, and the rest of the bacteria or other pathogens can be killed by our normal host cells immune response. But in case of the cancers, even if we are destroying or we are debulking maximum number, there are still some cells because these are our host cells, and these cannot be killed by our normal host immune response. That's why in some of the cases, even after giving the surgery or radiotherapy, we have to add some chemotherapeutic drugs. So after surgery some chemotherapy or after radiotherapy some chemotherapy can be given, and these are known as the adjuvant chemotherapy, that is adjuvant to the other modalities of the treatment. This is mainly done in case of the solid tumors. So solid tumor is present, we are just debulking it by means of the surgery and we are giving some chemotherapeutic drugs. So these are the problems what I am talking. So cancer cells divide rapidly, cell cycle is accelerated. So you know about the cell cycle in the physiology and biochemistry in the first year. So there are different types of the cells in our body that remains in different phases of the cell cycle. Some cells are in resting phase, that is the G0, and some phase go on in the G1, G2 synthetic and mitotic phase, so that the multiplication will happen. Now this normal cell cycle will be accelerated in case of the cancer cells, and even in cancer cells, most of the cells may be in the G0 phase, most of the cells may be in the mitotic phase or synthetic phase, and accordingly different types of the drugs are also discovered to target those types of the cells. That is, some drugs are cell cycle specific, that is, that kills most of the cells, those are in the G1 phase, example. And some drugs are also there, those are cell cycle non-specific, that is, that can kill the cancer cells irrespective of the cells are present in different phases of the cell cycle. So cell-cell communication is also altered in case of the cancer cells, normal cell-to-cell communication, the different types of the neurotransmitters. Uncontrolled proliferation, we know about this, invasiveness invades from one cell to another, from one tissue to another, and ability to metastasize to far away from the main areas. So the nodal area is somewhere far away from, and then it can metastasize to somewhat far away from. Okay. So general principles of the chemotherapy is analogous to bacterial chemotherapy, what I am discussing. That is, selectivity of the drug is limited, this is the difference. The selectivity of the drug is limited, no or less defense mechanism. All malignant cells must be killed to stop the progeny, and this is becoming difficult. We cannot kill all the malignant cells like that of the antimicrobial chemotherapy. Different subpopulation of cells in a malignant tumor differ in different rates of proliferation. That means in a tumor there are different cells, and that can in the different phases of the cell cycle, and also the speed of the cell cycle in different cells are different. So only one drug or two drug or three drug cannot act on all types of the cells that is present in one cancer or one tumor. That is the problem. So we can kill 60% of those cancer cells, but 40% will not respond, like this. So complete remission should be the goal. So our goal will be, as far as possible we reach towards the complete remission, done until the drugs used in maximum tolerated dose, because these are very toxic. Why toxic? Because these also acts on the normal host cells, because these cells ultimately block different types of the nucleoside synthesis or nucleotide synthesis, so that the cell cycle will not continue. And that also blocks the normal nucleotide synthesis in normal host cells to some extent also. That's why these are very much toxic. Formerly single drug chemotherapy was used, but it has been seen many cells will not respond, and many cells will also become resistant to those chemotherapeutic drugs. and also toxicity will be more. That's why we now using combination chemotherapy or concurrent chemotherapy, so that drugs that act on different phases of the cell cycle of a single tumor as well as their toxicity profiles are different, that these drugs can be combined together and this can be given as a regime. So usually you will see that cancer chemotherapy is given as a regime. Okay. So the principles for selecting agents, how we will select agents? So drugs known to be active as single agents should be selected for use in combinations. Preferentially drugs that induce complete remission should be included. That means on that cancer, that drug can kill maximum number of the cells, because we know in that tumor 70% or 80% cells are in this type of the phase of the cell cycle, and this drug is active against this type of the phase of the cell cycle. Drugs with different mechanism of action with additive or synergistic cytotoxic effects on the tumor should be combined, of course. Drugs with different dose limiting toxicity should be combined, because all the drugs, 3 drugs we are using, all they have dose limiting toxicity on the liver toxicity. So ultimately that will be very much high, liver toxicity. So this should not be done. Drugs should be used at their optimal dose and schedule. We have to increase the dose according to the tolerance of the patients. Drugs should be given at consistent interval. If you know, you will see usually the chemotherapy are given in cycles. That is, it is given in monthly or twice weekly. So it is given like in cycle or in regime. And the treatment period should be as short as possible to allow for recovery of the most sensitive normal tissue. So the normal host tissues are also suffering. So within this treatment period, between one cycle of chemotherapy and another cycle of the chemotherapy, the normal host cells will recover. Drugs with different patterns of the resistance should be used to minimize the cross resistance. Again, when you are using continuously similar type of the drugs, the cells, the proliferating cells, uninhibited cells becomes resistant to those drugs. So this is the cell cycle what we are discussing. So you know about this G0, which is the resting phase, and some of the cells, this is also present in the normal cells, all our normal cells. But cancer cells are usually present in this cell cycle becomes accelerated. So most of the cells, less of the cells are in the G0 phase and most of the cells enter within the cell cycle. So G1, this is the first phase of the cell cycle where the growth of the cells happens, that is increase of the size of the cells, and then it enters within the synthetic phase, S phase. In the S phase, different types of the synthesis happens. Enters the phase of the DNA synthesis, where the chromosomes are usually duplicated. Then it goes to the G2 phase, where the cell usually prepares for itself for the division. Now just at the prior to division, it enters into the G2 phase, and then comes to the mitotic phase or M phase, where the actual division happens, where the chromosomes are separated and ultimately segregated to daughter cells, and ultimately the chromosome setup happens. And then some of the cells go to the G0 phase or resting phase, and some of the cells again enter within the G1, and this ultimately continues this cell cycle. So ultimately the same thing you can see. So G1 resting, G0 is the resting state where cell is not dividing, no dividation. Usually those cells which are in the G0, they are maximally resistant to these chemotherapeutic drugs. So chemotherapeutic drugs are most sensitive when the drugs are replicating, when the cells are multiplicating. So again in the G2, synthesis of the enzymes needed for the DNA synthesis happens. DNA is replicated in the S phase. So within the cell cycle, usually 40 to 50% time is usually happens within this S phase. Then it goes to the G2 phase, where the synthesis of the cellular components required for the mitosis happens, and the cell just prepares for the division. In the M2, minimum time where the rapid multiplication happens, and then it continues. So already we have discussed. So what happens? A tissue with a larger percentage of the proliferating cells and few cells in G0, they have a high growth fraction. So we can say that there are some cancers which have high growth fraction cells, and there are some cancers which have low growth fraction cells, where the most of the cells are in the G0 phase. Now what happens? Cancer with high growth fraction cells, they are most sensitive to chemotherapeutic drugs. But cancer with low growth fraction cells, because they needs a long period of the time for multiplication, but ultimately the cancer remains. So here the chemotherapeutic drugs acts most poorly. Okay. So ultimately the fraction of the tumor cells that are in the replicative cycle, this is known as the growth fraction, that influences their susceptibility to most cancer chemotherapeutic agents, what I am talking. And we have discussed about some drugs are cell cycle specific drugs and some drugs are cell cycle non-specific drugs. So you can see from this picture, these are some examples, these are some classification as well as the names of the chemotherapeutic drugs and which are most active in which phases of the cell cycle. For example, mitotic phase, you can see M phase. In the M phase, vinca alkaloids group of drugs, example of the vinblastine, vincristine, vinorelbine. Vinblastine, vincristine and vinorelbine, this comes under the vinca alkaloids, very commonly used cancer chemotherapeutic drugs. This mainly acts on the mitotic phase. Again, you can see taxanes. Taxanes group of drug, example is the paclitaxel and docetaxel. This mainly acts in the first phase of the mitotic and some part of the G2 phase also. That is, this can act on the M phase as well as the G2 phase. There are some other drugs like etoposide, teniposide, bleomycin. This mainly acts on the G2 phase of the cell cycle. Topotecan, irinotecan, these are the topoisomerase 1 inhibitors. They mainly act on the synthetic phase. Most of the drugs you can see, different types of the drugs that are mainly active against the synthetic phase. Like these are mostly anti-metabolites, that is they are either blocking the purine synthesis or blocking the pyrimidine synthesis. These purines and pyrimidines are needed for the DNA synthesis, that's why. So there may be folate analogs like methotrexate. Already you have read about the methotrexate. Methotrexate is also used in case of the rheumatoid arthritis and this methotrexate is also anti-cancer drug. Purine analogs like cladribine, fludarabine, mercaptopurine, thioguanine, this acts on the synthetic phase. Pyrimidine analogs like capecitabine, cytarabine, gemcitabine, fluorouracil, commonly used, this also acts on the synthetic phase. Hydroxyurea also acts on the synthetic phase. In the G1 phase, different types of the hormonal drugs mainly acts. Hormonal drugs like already we have read about the tamoxifen. Tamoxifen is used in the breast cancer. ACRM, selective estrogen receptor modulator, that also acts on the G1 phase of the cell cycle. Asparaginase, PEG asparaginase, these are different types of the enzymes. This also acts on the G phase. So the picture ultimately depicts that these are the drugs that mainly acts in different phases of the cell cycle. So these drugs are also known as the cell cycle specific drugs. So if you are asked to give some example of the cell cycle specific drugs, so these are the examples of the cell cycle specific drugs. Okay. So these are now coming to the example of the cell cycle non-specific drugs. That is, these drugs can act on cells on those are in different phases of the cell cycle, irrespective of the phases of the cell cycle. Example, alkylating agents. Alkylating agents is the first chemotherapeutic drug that was discovered. Example is the busulfan, carmastine, cyclophosphamide, very commonly used, lomastine, mecloretamine, melphalan, thiotepa. These are the alkylating agents. These are the cell cycle non-specific drugs. Next, coming to the anthracyclines. Example is the doxorubicin, daunorubicin, idarubicin, mitoxantrone. These are also cell cycle non-specific drugs. Anti-tumor antibiotics. So these are antibiotics. These also kills the antimicrobes, but this also acts as an anti-tumor antibiotic. Example is dactinomycin, mitomycin. Captothixins like irinotecan, topotecan, these are also cell cycle non-specific drugs, and there are some platinum analogs like carboplatin, cisplatin and oxaloplatin. These are also very commonly used. These are also cell cycle non-specific drugs. Cell cycle non-specific drugs are usually very potent because this can act on different types of the cells in different phases of the cell cycle, but these are not very specific. That's the problem. So slowly growing tumors with small growth fraction drugs. Example is the carcinoma colon. Colon carcinoma is very much resistant to for example, very much resistant to the cancer chemotherapeutic agents, because these are slowly growing carcinoma and most of the cells are in the G0 phase and their growth fraction, that's why small growth fraction. So they are less responsive to the cycle specific drugs. So here usually the non-cycle specific drugs may be active. Even if they are active, they are less specific as well as they are less responsive, this type of the drugs. So more effective are the agents that inflict high levels of the DNA damage like alkylating agents, and those that remain at high concentrations inside the cell for extended period of time like fluoropyrimidines. So these drugs are very much potent because alkylating agents alkylate the DNA and ultimately destroys this even if the cells are present in different phases of the cell cycle. The clinical benefit of the cytotoxic drug has primarily been measured by radiological assessment of the drug effects on tumor size. Tumor size, how it is diminishes, and there are different types of the biomarkers are also there according to the tumors, and we have to test this frequently to see how much cycles of the drugs is usually needed for the treatment. So stem cell components can also be targeted. So tumor stem cells usually exhibit the same resistance to chemotherapy, and there are different types of the drugs that can also target these stem cell portions also. So this is the solid tumor life cycle. There are different other tumors also like hematological malignancies. This is usually solid tumor. For example, this is one cell, ultimately that grows, becomes uninhibited, unproliferated growth, proliferated growth. So malignant transformation, establishment of the cell growth happens. Usually when the number of the cells becomes approximately 10 to the power 9, you can see 10 to the power 5 to 10 to the power 9, rapid growth happens and usually the tumors become detectable. So before 10 to the power 5 cells, usually the tumor will not be detectable, that is asymptomatic. So what that means? That means when you are diagnosed with a cancer, when you are diagnosed with a tumor, already there is approximately 10 to the power 5 to 10 to the power 6 cells that has been proliferated. So after that it has been diagnosed. So already it has been in the much aggressive state. Okay. So here ultimately you can see the diagnosis by the biopsy, as well as when it has been diagnosed we start treatment. This only happens approximately 10 to the power 6, 10 to the power 7 or 10 to the power 8 cells are already there. It is already there. So that's why the treatment of the cancer is very problematic, because already there is much larger number of the cells. Usually in case of the solid tumors, usually if it can be surgically achievable, we will cut this, debulk this, and then we have to give the radiotherapy, chemotherapy, etc. So it becomes palpable. আমরা এটা ফিল করতে পারবো। Already you can see the tumor becomes 10 to the power 9 cells. Already it contains approximately 10 to the power 9 cells when it becomes palpable. Before that it cannot even become palpable. So ultimately when it becomes 10 to the power 10 and 10 to the power 11, it becomes regional disease and it can become metastasized. So you can see when the cell number increases to up to this, we are diagnosing this, and within very short span of time it becomes regional disease and it becomes metastasized. Very small short, that is the problem. And you can see the tumor mass becomes 1 kg when the number of the cells becomes approximately 10 to the power 12, and tumor mass becomes 10 kg when it becomes 10 to the power 13 cells. Usually when the tumor mass becomes 1 kg or like that, usually the death is ensuing. Okay, so ultimately death happens here. Here death happens and we are diagnosing here. Okay, so this is the problem of the cancer chemotherapy. So what I am talking, so may have up to 10 to the power 12 tumor cells throughout the body at the time of death, and 10 to the power 9 cells at the time of diagnosis. At the time of diagnosis 10 to the power 9 cells already there, 10 to the power 12 cells hoye gele, that will be death. And debulking surgery korle 90% it can be removed, but 10% is already there, and 10% again will go to the cell cycle and ultimately it will proliferate. That's why we have to give the radiotherapy as well as the chemotherapy. So that means still 10% left even after surgery. So 10 to the power 9 becomes just 10 to the power 8. 10% means ki 10 to the power 8. So ultimately 10 course or cells are there. So ultimately this is also known as the 8 logs. 10 to the power 8 means log, logarithmic scale. So 8 logs of the tumor cells are already there. So an effective drug is capable of killing 99.999%. There is effective drug if we do its combining. But even after this, there is 0.001% of the cells, and 0.001% of the 10 to the power 9 or 10 to the power 12 is also 10 to the power 4 approximately. So therefore, scheduling of this agent is particularly important. So this is known as the tumor kinetics that we need to know when we have to use the cancer chemotherapeutic use. These tumors characteristically exhibit a sigmoid shaped curve. This is also known as the Gompertzian growth curve. Remember the name Gompertzian growth curve. How that these tumors are increasing, what I have discussed, and where it should be given the different types of the therapies. So this is the Gompertzian growth curve. So you can see again, this is the tumor cell number 10 to the power 0 cells, and the highest is the 10 to the power 12 cells where usually death happens. And you can see approximately 10 to the power 9 cells, usually the clinical detection happens. Usually before that it is asymptomatic. There is no symptoms. It's clinically undetectable tumor, and rapid proliferation usually happens in these areas. Rapid proliferation. So even after detection there will be rapid proliferation, and within few months or years it ultimately reaches 10 to the power 12 if there is no treatment is given. Okay. So you can see slowly initial growth is slow, then the rapid cell proliferation and tumor growth, and ultimately it goes to the plateau. If it is not, the treatment is given, death ultimately given. So this is known as the sigmoid Gompertzian curve of the tumor kinetics. Okay. So chemotherapeutic agents usually kill a constant fraction of the cells, like that of the first order pharmacokinetics. If you can remember, in the general pharmacology, first order kinetics means constant fraction of the cells. Constant fraction of the cells are eliminated, and here the constant fraction of the cells are killed, not constant amount of the cells. Fraction usually killed. So this is known as the log kill hypothesis. Log kill. When we are giving some chemotherapeutic drugs, it kills a specific logarithmic scale fraction of the cells. Okay. So rather than a specific number of the cells after each dose. So solid cancer tumors generally have a low growth fraction, thus respond poorly to chemotherapy. Already we have discussed, and in most cases it is to be needed to be removed by the surgery. And when there is disseminated cancer, generally have a high growth fraction. Disseminated cancer, various metastases or hematological cancer, it becomes high growth fraction drugs. So in these cases, the chemotherapeutic drugs also act very good. Okay, well to chemotherapy. So you can see the magnitude of a tumor cell kill is a logarithmic function. 4 log kill means reduction of 10 to the power 12 to 10 to the power 8. 4 log kills. Now we can understand from this that these drugs can kill 5 log kills in 1 month, like this. Okay. So consequently, in the previous what I am talking, that a very good drug that can kill 99.999%. So after killing there will be 0.001%, but that also means 10 to the power 4 cells. But so even after killing 99.999%, the 10 to the power 4 cells will be there in the tumor. So that is the problem. In case of the microbes, this is known as the 5 log kills. Usually on an average, when a drug is given, when a very good effective drug is given, that can kill 4 to 5 log kills. Okay. Similarly, in case of the antimicrobial chemotherapy, it also gives this 4 to 5 log kills, but this rest of the 10 to the power 4 microbes usually are taken care of our own immune system. But here our immune system is already compromised. So that's the problem. So this is known as the 5 log kill. So 5 log kill, that is 10 to the power 9 to it becomes 10 to the power 4. So most bacterial infections already I have discussed about this. So you can see by means of the different types of the measures when we will do to the cancer, what happens. So this is again the Gompertzian curve. So when we will do some surgery beforehand, ultimately it diminishes, the debulking of the main tumors happens, but again there will be multiplication continuing. So when we are adding this with some drugs again, so ultimately that leads to very low multiplication potential, and if there is no drug is given, ultimately there will be increase of the multiplication and there will be death. So ultimately dark blue line, this is the infrequent scheduling of the treatment courses that leads to the kill rate of the tumors is less than the growth rate, and this light blue usually we needed where the kill rate should be more than the growth rate. So there are some tumors whose growth rate is more, some tumors whose growth rate is less. So accordingly we have to use those regimes of the drugs so that the kill of the tumor cell rate in the logarithmic scale would be more than that of the growth rate. So that should be done. So green line is early surgical response and then giving some drugs. So now coming to the neoadjuvant chemotherapy. So adjuvant chemotherapy is firstly we are doing some surgery or radiotherapy, then we are giving the chemotherapeutic drugs. Neoadjuvant means firstly we are giving some drugs. Okay. So here in some settings like bulky testicular cancer or stage 3 breast cancer, surgery is not the first treatment modality used because the surgery is very cumbersome, very problematic. So here after an initial diagnostic biopsy, chemotherapy or in some cases chemotherapy plus radiotherapy is usually given to reduce the size of the tumor to some extent as far as possible, and then control it, and then we will do some surgery, and it is also done in case of some metastatic disease. So such therapy is followed by a surgical procedure to remove the residual masses. So this is known as the neoadjuvant chemotherapy. So we can do adjuvant chemotherapy where the chemotherapy is given last, neoadjuvant chemotherapy where the chemotherapy is given first. Okay. So early intensive therapy start to the treatment is helpful. Usually combination of the therapy of the different drugs that have different mechanism of action should be started. Complete remission should be our goal. That is those drugs that have maximum killing effect should be started. Combined chemotherapy or combination concurrent chemotherapy is usually given. Combined chemotherapy can be curative when applied to minute residual tumor cell population after surgery or radiation. So after surgery or radiation, very minute is present, we can give the drugs. Treatment must continue past the time when cancer cells can be detected using conventional techniques. In many of the cases, you know that drugs have to be continued lifelong so that there will be no recurrence, because there may be recurrence. The tumor cells are already multiplicating, but it is in a very low fashion. That's why it is clinically undetectable. So when we say the patient is in remission, the cancer have not got back, ultimately there will also be multiplication, but that is also very low level, and we are also giving some drugs that keeps it in the low level. Okay. So when cure of the cancer is possible, cancer treatments may be considered despite certainty of the severe and perhaps life-threatening toxicities. So basically we have to maintain a balance, that is whether this toxicity can be acceptable or not in comparison to the prolongation of the life. Every cancer treatment has the potential to cause harm. That's why these are very toxic. That's why in case of the clinical trials, usually you know in the phase 1 trial, the healthy volunteers are chosen. In case of the cancer chemotherapeutic drugs, usually even if in the phase 1 trials, patients are chosen to see what is the pharmacokinetics as well as the safety of the drugs. The therapeutic index of the many interventions may be quite narrow, very low therapeutic index of these drugs. When the clinical goal is palliation, careful attention to minimizing the toxicity is needed. That is like pancreatic cancer, stage 4 pancreatic cancer. Ultimately death will happen because the multiplication is very high. So here we are giving some drugs so that there will be some prolongation of the life, and also the quality of the life should be maximal. That's why here we should use those drugs where the toxicity is less. Okay. Again, the treatment of the cancer patient requires a skillful interdigitation of the pharmacotherapy with other modalities. Each treatment modality carries its own risks, and accordingly we have to choose. So for each different types of the cancer, there are different types of the treatment algorithm. Individual patient characteristics, age, sex, racial, what is the race, what are the different comorbidities, all should be taken into account. Renal and hepatic function, very important. If the renal compromise at the last, we should not use those drugs that ultimately have very nephrotoxic potential. Other less quantifiable considerations are natural history of the tumor, that is what is the growth fraction of the tumor, how it increases, the patient's willingness to undergo difficult and potentially dangerous treatment, because all these drugs have different types of the adverse effects, and the patient's physical and emotional tolerance for the side effects. All these should be taken into consideration when we are choosing the treatment for those cancer patients. So we have to adjust the drug regimens to achieve a therapeutic but less toxic and non-toxic outcome. Usually the drug is given according to the body surface area. We have to account the dosage. Orally administered drugs are now frequently prescribed using uniform dosing for all adult patients. Dose adjustments is usually given according to the pharmacokinetic parameters, and elderly patients, because many of these cancer patients are elderly, so we have to again consider about their hepatic function, renal function, different other comorbidities also, and also their bone marrow reserve. Drug clearance, that also decreases, for example, in morbidly obese patients, also in case of the elderly patients, and accordingly we have to decrease the dose. Molecular tests, different types of the molecular tests, difference of the mutations, all this can be tested, details are not required. So you can see tandem repeats, these are the how you will diagnose as well as the prognostication. That is when we are using the drugs, we have to test these different types of the parameters, biomarkers, to see how the treatment is approaching. Resistance to the chemotherapeutic agent, that may be intrinsic resistance, that is this drug we are giving, the cells are in the some other cell cycle, or the cells are in the G0 phase, we are giving some cell cycle specific drugs. So these are inherently resistant to those chemotherapeutic drugs, and some are acquired because we are giving some single drug. Change in the genetic apparatus may happen so that the tumor cells will not respond to those drugs, and that may be multi-drug resistance also. So this is more or less similar to that of the antimicrobial chemotherapy. Toxicities, very much toxic, already we have seen, very much harmful, mostly in case of the GI mucosa, bone marrow, reticuloendothelium cells, different types of the epithelial cells, gonads and hair cells. Why? Because these are the rapidly proliferating cells. Our normal mucosal cells or this type of the cells, bone marrow cells, these are the rapidly proliferating cells, and already we know that these chemotherapeutic drugs are very much ultimately very much active against the rapidly dividing cells. That's why the toxicity will be more towards this. So bone marrow depression may happen. That's why ultimately this is a very dose limiting as well as the rate limiting steps when we are treating the drugs. When the bone marrow depression happens, neutropenia happens and different other problems happen. Buccal mucosa erosion, mouth mucosa, due to high epithelial turnover, so there may be bleeding gums, stomatitis may happen. These are more or less common adverse effects of different chemotherapeutic drugs. In the gastrointestinal system, again the gastrointestinal mucosa can be slurred, so there may be diarrhea, shedding of the mucosa, hemorrhage may happen. Nausea, vomiting may happen because the CTJ center in the brains are usually stimulated. In the skin, there may be alopecia. So this is very common, alopecia. All the hair loss is a very common on the cancer chemotherapeutic drugs. In the gonads, again that is the rapidly proliferating cells are there. That's why there may be oligospermia, impotence, amenorrhea, infertility, all this can happen. Lymphoreticular system, it may be lymphocytopenia, lymphocyte function may be deranged. Susceptibility to infections usually happens when we are using cancer chemotherapeutic drugs. The patients become more susceptible to different types of the infections. Carcinogenicity, the anti-cancer drugs are itself carcinogenic because they mainly act on normal cells that have high turnover. So there may be problem. Teratogenicity and hyperuricemia. So most of these drugs are teratogenic. So they, when these are given in the pregnant patients, they can lead to teratogenicity and also hyperuricemia because some cancer cells are destroyed. When the cells are destroyed, the uric acids will be more in the blood. So countering the toxicity, there are different types of the drugs or measures are also there to counter the toxicity of the anti-cancer drugs. For example, you know about this folinic acid rescue. This is mainly done in case of the methotrexate. So this is also common question why the folinic acid is given. So methotrexate toxicity, hyperuricemia, uricosuric agents like allopurinol can be given. When the platelet count is very low, we have to transfuse the platelet. When the neutrophil count is very low, we can transfuse the different types of the colony stimulating factor, growth factor we can give. So variation in sensitivity is already there, already we have seen. For example, this lymphoma, leukemia, small cell lung cancer, testicular cancer, they are highly sensitive to the chemotherapeutic drugs. These are examples. Intermediate sensitivity is the breast cancer, colon cancer, non-small cell lung cancer, and very low sensitivity to the cancer chemotherapeutic drugs at the head and neck cancer, prostate cancer, gastric cancer, pancreatic cancer, etc. So accordingly, for example, if there is pancreatic cancer, mainly we are using the cancer chemotherapeutic drugs for palliation. So that there will be less pain, quality of life improved, like this example. But when there is, for example, testicular cancer, it is more or less fully curable. Here we have to give different types of the regimes of the cancer chemotherapeutic drugs, like this. Okay. So the pharmacokinetics and toxicities of the cancer drugs vary among individual patients. It is imperative to recognize the toxicities. Toxicities affecting the heart, lung and kidneys may be irreversible. So that is the problem. So when we are giving the drugs, the adverse effect may be irreversible in some of the cases. And the toxicities can be minimized by early recognition and by adherence to standardized protocols. So after this cancer chemotherapy principles, we will start individually one by one about the different types of the drugs. I am just showing, already we have showed about the different names of the drugs. I am already showing the classification. So already we have discussed in the cell cycle specific and non-specific drugs. So it can be classified according to the chemical structure. So there are different types of the groups according to the biochemistry or mechanisms, that can act on different phases of the cell cycle. So they can purine analogs, pyrimidine analogs, they are anti-tumor antibiotics like this, or according to the phase of the cell cycle, already we have discussed. So there are some drugs that can block the nucleic acid biosynthesis like antimetabolites. So these are mainly active against the synthetic phase. Already we have seen the names like folic acid antagonist that inhibits the dihydrofolate reductase like methotrexate, pyrimidine antagonist like inhibits thymidylate synthetase like fluorouracil, inhibits DNA polymerase like cytarabine, purine antagonist like 6-mercaptopurine, 6-thioguanine, ribonucleoside diphosphate reductase antagonist like hydroxyurea. That is, these are mainly acts at the metabolism of these cancer cells, purine analogs, pyrimidine analogs, and different types of the enzymes that are mainly active in the synthetic phase, they are mainly blocking. Okay. Now coming to the alkylating agents. So already we have seen about these examples. Again I am showing the names. Cyclophosphamide, usually the most common. Apart from this, there is meclorethamine, E-phosphamide, chlorambucil, melphalan, busulfan, different types of the platinum compounds like cisplatin, carboplatin, imatinib, antibiotics, anti-tumor antibiotics like bleomycin, mitomycin C, topoisomerase inhibitors like camptothecin analogs, podophylotoxin, again actinomycin D already have seen. So basically they influence the structure and function of the DNA. So basically they are these alkylating agents, that means alkylates the DNA so that it can be destroyed. Platinum compounds also destroys the DNA like this. So here this classification you can see there are mixed of the cell cycle specific as well as the non-specific drugs. So in the previous ones we have seen about the classification according to their cell cycle specificity. So here you can see alkylating agents. So this is the cell cycle specific drugs. Again similar types of the mechanism of action, platinum compounds like cisplatin, carboplatin, etc. But these are usually cell cycle non-specific. So we can classify the anti-cancer drugs according to the various ways. That's why. Okay. So there are some drugs that interfere protein synthesis like zinc alkaloids. Already we have seen zinc alkaloids like vincristine, vinblastine, taxanes, paclitaxel and docetaxel. So we have seen this mainly acts on the synthetic as well as the G2 phase. These zinc alkaloids and taxanes. So they mainly anti-tubulin, that is tubulin protein. They are how they are intercalating. These are mainly blocked. So they bind tubulin, destroy spindle to produce the mitotic arrest. they can influence the amino acid supply to the tumor cells like L-asparaginase. So there may be hormone synthesis influence. Already many of the drugs you have read about this, like the tamoxifen. Tamoxifen is a selective estrogen receptor modulator mainly used in breast carcinoma. That may be flutamide and bicalutamide. Already you have said. These are the androgen antagonistic drugs. Mainly these are used in the prostate carcinoma. Again, the progesterone like drugs like hydroxyprogesterone. Different types of the corticosteroids, glucocorticoid drugs. These are also used very commonly in case of the cancers like prednisolone, different other corticosteroids. Gonadotrophin releasing hormone inhibitor like nafarelin, triptorelin. Again, aromatase inhibitor like letrozole and anastrozole. So all these drugs are basically you have read in the hormone chapter. So these are the hormone drugs, but these can also used as an anti-cancer drugs. Okay. So from the next class we will discuss about the alkylating agents. So this is all about the principles of how the cancer cells are treated and different classification, different names of the drugs. Again, I am showing about according to the cell cycle specificity, names of the different drugs. Okay. So you can see this is the cell cycle specific drugs of the different chemical structure, of the different mechanism of actions. Okay. This acts on the different areas of the cell cycle, and these are the cell cycle non-specific drugs. From the next class, first we will start with the alkylating agents. This alkylating agents is a cell cycle non-specific drugs like this. Okay. So thank you.